First of all, a warm welcome to everyone who's joined us this afternoon for our BAPM webinar entitled Aligning Pre-Hospital Care and Neonatal Services. So what we're going to go through is the recently published in the middle of February, 15th of February, a new framework for practice which BAPM developed in conjunction with the College of Paramedics and the Royal College of Midwives. And this came about because of some concerns regarding perceived inconsistencies in management of extreme preterm birth out with the hospital setting and in the hospital setting. And so the idea is that we can all come together, understand each other, and really most importantly provide consistent empathetic care for extremely preterm babies and their families should you ever be in the unfortunate position of having to attend an extremely preterm birth out of hospital. So just a few housekeeping issues before we get started. You've all been informed that this meeting is being recorded. For logistical reasons, we're actually doing it as a Teams meeting rather than a previous webinar form. It was just some slight technical difficulties, but I presume slight differences. But I presume everybody will be pretty familiar now with Teams. So we've got 4 presentations of about 15 minutes each, and then we will hopefully have a full half an hour for a Q&A session. If you would like to contribute, then if you're happy with that, we would like to put your hand up and then switch on your mic and your camera and join a conversation. If you prefer not to do that, then obviously, as with other Teams meetings, you can join in through the chat function. And if I could ask people please to keep their mics and cameras off during the talks. So I think that's all the housekeeping. And without further ado, we will proceed to the first talk, which is the perspective of the ambulance crew. Now, this was going to be a joint effort with Amy and Amanda. Unfortunately, Amanda has, at very short notice, been unable to attend today, but I'm assured she's okay. So we send our best wishes to her. And I'm going now to hand over to Amy to give us the ambulance crew perspective. Thanks, Amy.
If I can get my camera to work. Thank you so much, Wendy. Thank you for Helen for that warm welcome. I'm just going to very quickly attempt to share my screen, and if I can actually get this to play, that would be good. There we go. The one at the bottom. There we go. So thank you all for joining us. My name's Amy Yarrington, and I am the College of Paramedics representative that sat on these guidelines, along with Amanda Mansfield, my consultant midwife colleague from the London Ambulance Service, as well as Dawn Kerslake, who's also the consultant midwife for CCAM. So this piece of work came about following a piece of work that we did with the Embrace UK on the clinical guidance for the signs of life in births before 20 weeks gestation. And we were all involved within this working group as a piece of work that was done about recognition of the signs of life. But this was very, very clearly put out as a framework for the in-hospital use. So you guys from BAPM are probably very, very familiar with this piece of work, but it was a new piece of work for us from a pre-hospital perspective, because this was very much found to be a grey area when it came to looking at the sort of the pre-hospital guidelines. We found that when we looked and when we were involved with this working group, that there was a big sort of patch of work that hadn't been completed, and there was a lot of pre-hospital clinicians that found this area very, very difficult to manoeuvre. Obviously, there was lots of ethical considerations, there was lots of legal considerations that crews were being faced with, not on a daily basis, thank goodness, but on a fairly regular basis. So we discussed as this working group that we needed to take this piece of work further, and we approached BAPM, who were more than happy to work with us following on from this to produce the guidance and the framework. So you can see from the Embrace report, the births clearly state that there were in-hospital births only. And we sort of alluded to the fact that these principles may apply to pre-hospital births, but we were very much sort of aware that there was not that hard and fast evidence that we like to see in our groups. So we approached this piece of work, and when we looked at this new framework for pre-hospital, one of the most difficult sort of areas that we looked into was the fact that we haven't really come across this framework before. This is something that's pre-hospital clinicians, we are not used to having to deal with. We have very, very short space of time once we're given cases for the guys that work in hospital. We're allocated cases. You might literally have 5 to 10 minutes before you arrive on scene, if you're lucky, to actually sort of get into your headspace as to what you're going to be attending. Very often you don't know what it is you're attending. You arrive on scene and you could be faced with a baby that has been born at the extreme of gestation, and you could be completely and utterly unprepared for that situation. So having a quick reference guidance to go to that tells you what you can and what you are and what you can, can and cannot do, or what you should and shouldn't do, is really, really important for us making those critical split-second decisions. Because when we think about what we actually have to go through in that sort of very, very quick rapid assessment of this situation, pre-hospitally, like I say, we have very limited time frames to actually get together at what we're going to actually plan and do, whereas in hospital, some of the time, I know, granted not all the time, but some of the time we have a chance to prepare parents for what might be happening, to give them the preamble about the chances of survival, etc. We very often don't get that. So having a simple algorithm like this one here that that you can see on the screen was really important to us, and we made sure that when we were looking at something to put into the guidance, it was something that could be followed easily and quickly for pre-hospital clinicians to use. So for those of you that don't work in the pre-hospital environment, there are several layers of clinician that are working within that area. So we don't, we always, not always there will be a trained and qualified clinician such as a paramedic in situ. There may be a clinician such as a technician or an ambulance care assistant or an associate ambulance practitioner who are unregistered practitioners, who again have to have a guideline to follow that is very easy to want to understand, and secondly for them to follow it is making those split-second decisions. So this is a completely new concept for pre-hospital clinicians, and this will align with the JLCalc guidance that is being released in the new newborn life support, which should be coming out at the beginning of May in the next update to the JLCalc. So the introduction of stabilisation versus non-intervention is something that has not been seen before with maternity care. This is something that is completely new to pre-hospital clinicians, and for our BAPM colleagues, this is something that probably will be asked to you when you have pre-hospital clinicians that come towards you. So if you can use your time with the pre-hospital clinicians to guide them through this, they probably will have lots of questions about what we should and what we shouldn't be doing. We made it very clear that if the gestation was known, that to be less than 21 weeks and 6 days, that we should be focusing on comfort-focused care. But that's also the case if the gestation, that is only the case if the gestation is known. If the gestation is known to be over 22 weeks, then we are moving ourselves toward active and survival-focused care. But if the gestation is uncertain, then we must be very, very clear that we would go down that stabilisation route rather than the non-intervention route. So it gives the clinician that ability to make that decision on scene. So the actual advent of comfort focused care, then, as I say, this is going to be something that is very, very new to pre-hospital clinicians, something that has not been taught before, something that has not been given out as an option previously. So the main focus is around comfort focused care then is about easing emotional distress, about trying to reassure parents, making sure that they are providing that baby with the comfort that it needs in these few moments, or while they may potentially sort of make these sort of gasping or reflexing movements, making the parents aware that you know, the baby is not able to feel pain, etc., and to make them feel comfortable to be able to provide this care for them. There's the important aspects of memory making, etc., because even though as pre-hospital clinicians you may feel that you don't have that sort of impact on it, but these early memories, and these probably only memories that the parents will have with their babies, are extremely important. So being able to facilitate any sort of memory making is really, really important. The use of language, making sure that we are being kind and considerate with our language, and making sure that the parents aren't forced. If the parents do not want to hold or do provide skin to skin with their baby, it's not an enforcement. If the mother feels she's not able to, is there a partner or another person there that would be able to do skin to skin? If skin to skin's not appropriate, the use of a cuddle pockets, which are available in many, many ambulance trusts now, can also be used as a dignified way of providing transportation for babies less than the 22 weeks gestation, 21 weeks and 6 days gestation. And if they're not available in your trust yet, then please, please ask why not, because these are very important when it comes to the use of facilitating these memories, etc. When we look then at this sort of area from 22 weeks, then from the 22-week gestation up until the 24-week gestation, where the newborn life support guideline will take over. This is also what would be provided if your gestation is unclear. So if you were not sure what the gestation was, but you were uncertain if they were at the 24-week point, then we make sure that we are making sure the baby doesn't get cold, providing our optimum temperature, still deferring our cord clamping, and we would not provide chest compressions if they were below 24 weeks, obviously, as we say, but the making sure the baby maintains their temperature is absolutely vital. So this will be in the new updated GelCalc guidance, the use of a polythene bag for babies, placed feet first, up to the neck, wrapped, and then an appropriate heated mattress if that is available to you. The focus is on maintaining airway and breathing rather than the circulation, like I said. And there's going to be another talk later on about the destination for where we're going to take these babies to. So it's just a sort of very brief overview, really, of the new newness of this guidance for ambulance clinicians, and just to make sure that our BAPM colleagues are aware that this is something that is a brand new concept for pre-hospital clinicians. And there will be another webinar that is taking place for the college on the 16th of April, which will be looking further into the comfort care aspect for our pre-hospital clinicians. And we'd be delighted if you come along to that one as well. I think I'm nearly up to my 15 minutes, judging by my clock.
Thanks, Amy. That's fantastic. A great start and a great overview. So just to emphasise, to pick up on what you've been saying, this is a joint effort. The whole point of this framework for practice is so that we are all singing from the same hymn sheet and giving the same message to parents in what is really a terrible, stressful situation. What we don't want is ambulance crews arriving at the hospital and the neonatal team say, "What on earth did you do that for?" and such like that. So if you take nothing else from today's meeting, it's that we all want to be doing the same thing, and that will come through hopefully in the discussion later on. I'm delighted we've got over 100 delegates signed in at the moment, and we're roughly 50-50 between ambulance crew, paramedics and in-hospital neonatal clinicians. So that's great that this is a team show. So the next talk, we're going to move on without further ado to the neonatal perspective. And this is Dr. Neil Ayton, who is a consultant neonatologist in Brighton. He was involved in the group, and he also has a lot of experience of out of hospital, well, obviously all transports out of hospital, of neonatal transport services in the southeast. Unfortunately, Neil couldn't be with us in person today, so we have a pre-recorded talk, which I'm hoping either Marcus or Kate will magic upon the screen.
I'm delighted to be able to present the neonatal perspective at the launch of this new framework for practice, which has been hosted by the British Association of Perinatal Medicine, but very much continues the important tradition of the true multidisciplinary input, with important contributions from our paramedic colleagues, the ambulance service, and the Royal College of Midwives. This is a piece of work which, as I will explain in a moment, has arisen from direct experience of families and from a professional desire to work together to improve the situation for families in the future. It's not perfect, and as with all such documents, there are aspects of compromise necessary to come up with something that is both workable and practical, and not just theoretical. It's been a privilege to work together with others in the group in that process. This framework arose from some understanding that we were seeing cases in the Pan Sussex Child Death Overview panel where resuscitation was attempted on extremely preterm infants below the level of viability, even down as much as 16 weeks, and that this on occasions had caused significant distress to the parents. Parental distress had also been caused in different situations because of their experience of professional confusion and disagreement between what constituted appropriate signs of life at this gestation, and therefore the reasoning for initiating resuscitation. There was also professional dissatisfaction because of what was felt to be professional obligations, particularly for those on the paramedic side of things, where the expectation was that of active resuscitation, even when they themselves didn't concord with what seemed to be the right thing to do in particular circumstances. Much has been learned over the last couple of decades about the importance of acknowledging births in helping mothers to deal with grief over the longer term, even when this has occurred before a gestation where survival might be possible. Organisations like SANS have been instrumental in driving that forward. However, we must be careful that in our wish to acknowledge and register births before the age of viability, we're not also at the same time encouraging inappropriate resuscitation of newborn infants where survival would not otherwise be possible. The BAPM framework on perinatal management of extreme preterm infants was an important document that helped us to give a more nuanced approach to the assessment of risk and survival at these margins of viability. However, it was interesting to me in early discussions with our local South East Coast ambulance service that this was translated into an intention to resuscitate in all circumstances, with an extra 2-week margin down to 20 weeks added in to allow for the possibility of error. The instruction of the guidance for determination of signs of life has also been helpful within this process, and I'm sure that all of you will be familiar with both of these documents, which are downloadable from the BAPM and the Embrace websites respectively. Neonatologists will be all too familiar with the figures regarding survival at under 24 weeks gestation and the risks of disability in those who do survive. For any professional who is likely to be involved in this type of situation, their prior experience is likely to be limited, and they might feel poorly equipped to handle a complex evolving situation in the community, together with additional emotional side of things added in. It's sometimes easy to forget this, particularly from the advantage of the hospital, and it can be useful to spend a moment to imagine how we as neonatologists might handle a similar situation outside of the normal neonatal unit situation. So empowerment of decision making and making any guidance as simple as possible is crucial. There can sometimes also be significant uncertainty, particularly with respect to gestation, or occasionally the ability to communicate this, particularly if there are difficulties over language. We must also remember that the expectation within the ambulance service is that of responding to emergencies and providing resuscitation where that is required. So an important part of this guidance is about making it clear when attempted resuscitation would not be appropriate, and about what providing care in this type of situation might look like. There is, of course, in most situations, a likely need for transport as well, and local arrangements about where and how this is best provided will differ in different regions across the country. In the situation where resources are limited and likely survival chances for a baby at the margins of viability are low, it is important that due priority is given to the maternal situation. In some cases, there might be considerable complexity in this decision making, including the possible need for 2 ambulances and different places for the mother and baby to even be transported to. Even in the most experienced hands, with optimal equipment and antenatal preparation, the chances of survival are low at this gestation, and the risks of significant disability are high. And clearly these risks are increased even further for babies at this gestation who are born outside hospital. There's therefore a need to navigate between the two extremes of everything must be done and not intervening in a situation where survival might be possible, but there is also a high risk of disability. Providing interventional resuscitation in a situation where survival would not be possible is of no benefit to the baby, as well as offering false hope to the parents, and such is the case for babies under 22 weeks gestation at the present time. For some parents, however, above 22 weeks gestation, it might be important for them to feel that their baby was given every chance, even if the baby did not in the end survive. It is, of course, extremely difficult to provide appropriate counselling with parents in a rapidly evolving and emergency situation, and it's reasonable to err on the side of caution and recommend providing resuscitation when there is professional as well as gestational uncertainty. It was hoped, therefore, that the introduction of this type of guidance would mean that resuscitation was not provided inappropriately when this would be of no benefit, and just because there was an expectation. In this respect, one hopes that comfort care is seen as a positive option, and trying to include something about what this means. John will be discussing later about the approach to resuscitation in more detail. The principles contained within the framework for practice are outlined here: correct assessment, correct management, correct destination, and the use of good communication. Assessment of gestation is crucial, or understanding whether there is significant uncertainty. There is then a simple choice between offering comfort-focused care or providing survival-focused care. As neonatologists, we will be well aware of the importance of good thermal care, and this may be even more challenging in the out-of-hospital situation. Even if survival-focused care is provided in babies between 22 and 23 weeks gestation, you have an extremely low chance of survival. Following expert assessment in hospital, it is then possible for care to be reorientated at that point. So what does comfort-focused care mean? This is about encouraging active parental involvement in care, which may require considerable encouragement and support when parents might be very frightened, anxious and unsure. The importance of memory making, for example, encouraging taking of photographs, cannot be underestimated, and how this can be so helpful later as part of the grieving process. Sometimes there might be reasons why parents are unable to contribute to looking after their baby, either because they are incapacitated by fear or for medical reasons. In this situation, it can be really important for a healthcare professional, either a midwife perhaps or a paramedic in the community, to take responsibility for cuddling and looking after the baby. Warmth, comfort and dignity are crucial components of the strategy. The picture here shows a cuddle pocket which some ambulance services and community midwifery services have started to carry, but it is of course possible to improvise. Parents are likely to need continued emotional support and reassurance in an ongoing way, and in particular reassurance over interpretation of normal movements and gasps, which can be part of the normal dying process. Sometimes very emotive interpretations, like the word struggling, can be given or ascribed to these movements, and this is where reassurance is particularly important. The use of sensitive and appropriate language is very important to parents and will be long remembered, and the guidance contains some important suggestions. Finally, the guidance includes some possibility of switching to comfort-focused pathway if the initial approach to resuscitation is clearly unsuccessful. So what does the neonatal team need to do? Of course, as a neonatologist, our prime duty of care is towards our patient, in inverted commas, the baby. And the prime consideration is always what is in the baby's best interests. And along with that come a secondary care and support for the parents. Here, whatever the outcome, hearing their perspective about what happened subsequently, along with their worries, concerns and questions, is important. Early discussion and reassurance over the potential what-if questions can help to alleviate unnecessary worry, as well as exploring unanswered questions. For many of the professionals too, those who were involved, this would have been a highly stressful situation outside the limits of their normal professional experience. And perhaps we have a role here in reassurance, support, and helping to debrief at an appropriate moment. Organisation and timing of a debrief can be very challenging across different organisations as well as professions, but the importance is being increasingly recognised. Giving of later feedback can be very valued by some professionals who have been involved in these type of situations, and it is difficult to remember to do so as well as to find the time to do it. Examples of later feedback can be regarding the subsequent progress if the baby survives, or perhaps when results might come back later which explain why a particular baby was born early or might not have survived. I would like to just say a final word regarding death certification. Obviously, if signs of life are present at birth, even if only for a short period, then the baby must be registered as a live birth, and a death certificate will also be required. The regulations are very slightly different here between England and Scotland. If the baby is over 22 weeks gestation, then it's reasonable to use prematurity as a cause of death along with other additional causes or antecedents if they're appropriate, those which led to the birth. That is the B, C, D and E on the death certificate for babies dying under 28 days of age. However, I would suggest that it is probably not appropriate to use the description prematurity as the cause of death in babies under 22 weeks gestation, as we do not consider survival to be otherwise possible. Locally in the southeast, in the absence of a wider debate and consensus, we're trying to classify these deaths as being of pre-viable gestation. To those who might not agree with that suggestion, I would encourage the gestation to be recorded on the death certificate. So finally, in conclusion, there's now an appropriate guidance available for management of the extremely preterm infant born out of hospital, which does offer alternative pathways and hopefully will mean that resuscitation is not provided when this might be inappropriate, but is provided when there is some chance of survival. The pathway allows for reorientation when resuscitation is not producing a response. Hopefully, this provides an appropriate balance and will improve things for parents in the future. It's been a privilege to work with others, and the benefit of including different groups of professionals in this process has been crucial to the development of this guideline.
Okay, so I'm sending virtual thanks to Neil for that really great resume of the guidance, and I would just echo Neil's thought that it really was a huge privilege to work on this group, a truly multidisciplinary group. What we'll do now is we're going to move on. Neil made some reference to the fact that we've had to slightly tweak NLS recommendations in order to develop a very straightforward, pragmatic document. And we're very privileged this afternoon to have John Madar, who has a role on the Research Council. Thanks, John. And he's going to go through NLS teaching and how that's adapted to this situation. Thanks, John.
Hi, Helen. I don't know. I hope people can hear me. I'm not sure it's a privilege having me here. You'll just have to suffer for the next 15 minutes. But what I'm going to do, what I'm trying to do, and please let me know if you can't see the slides, is just briefly run through how the NLS approach aligns with this document. And hopefully you'll see, in fact, that it aligns in a way which makes sense to most people. So there are differences between out of hospital and hospital setting. And the question is, how does that affect the approach to the management of the baby at birth? And in this case, particularly the preterm baby, and impacts on the staff and the family, and so on and so forth. The key message is that the guidelines are unchanged. So people should be reassured. This is not a major deviation from current approach to the resuscitation of the newborn. It looks a little different in the simplified algorithm in this document, but when you look at it, it's the same. And it is survival focused care, prioritising thermal care and then airway and breathing, which is what we've always done and we continue to do with the NLS algorithm on the left here. So it's the same principles. There are issues, as others have said, about risk stratification. There are challenges in the environment, in the equipment. There are challenges in the people, the personnel at the scene, and there are limitations in what you can achieve in babies at certain gestational ages. But the principles are the same. We try, we cover, we assess, we consider cord management, we concentrate on airway and breathing with inflation and ventilation breaths, and for certain babies where it's appropriate, we move on to circulation and chest compressions. And in the out-of-hospital situation, the issue of venous access and drugs is one of discussion. And in the babies we're discussing today, the extreme preterm, arguably these are not appropriate interventions. Ideally, in the community, you'd have low risk babies only, but it's not always possible. And unfortunately, there are unanticipated deliveries of babies in homes and in other environments, supermarkets, cars, trains, planes, automobiles, and so on and so forth, with unanticipated problems. And even when midwives are at deliveries at home and they anticipate an uncomplicated baby, problems can still arise. So we do need to be aware of that and be able to respond. It's a potentially hostile environment. I use the word hostile in a guarded fashion, but it's not a controlled environment where all the resources are available. It is a compromise. Some facilities are not available. The equipment that is available in the out-of-hospital setting is not the same. And that means that there has to be a reliance on an altered approach to recognise the resources available. Some things, such as oxygen monitoring, are not really available to some people. And as mentioned before, the people at the delivery are different and their training is different. And while some may have newborn life support training or experience of resuscitation in the newborn, it may be something that's experienced very infrequently and therefore something which is a challenge at a number of levels. But pre-hospital NLS is essentially the same and just needs to recognise some of these aspects. So on the scene, we don't really expect antenatal counselling in the situation of an emergency call. There's limited ability to plan, limited time, limited resources. So whilst our algorithm talks about team briefing and equipment check, that's not necessarily something we can expect in the same way, although there is still going to be an element of briefing and on-scene assessment of the environment and what's going on. If we follow the algorithm down, birth, delayed cord clamping. Well, there's no reason why cord clamping should not be delayed in a hospital, in an out of hospital setting, but it does need to be thought about and at least recognised in order that this takes place. And for the extreme preterm baby, this can be of considerable advantage in terms of outcome and in terms of hemodynamic stability. And then it's the drying and the wrapping and the thermal care, and this is a vital aspect for all babies, but particularly for these preterm babies. And so quite a lot of emphasis has been put on thinking about the thermal care and how this might be effectively achieved in a compromised surrounding using those things available. And adjuncts such as exothermic or thermal mattresses and plastic wrap are vital in trying to achieve stability and temperature stability. Skin to skin is important in terms of this is a radiant heater. And preterm babies, the extreme preterm babies, they need special considerations. In newborn life support, we talk about stabilization versus resuscitation insofar as the majority of preterm babies don't necessarily need resuscitation, but they do need stabilization in order to achieve best potential. In the algorithm, we talk about placing undried in plastic wrap for radiant heat, a challenge in the out-of-hospital environment, but an exothermic mattress is radiant heat, and a baby can be placed in a plastic wrap and put on an exothermic mattress, providing it's been wrapped in a towel, because the exothermic mattress is potentially damaging to the skin. Meanwhile, thinking about delayed cord clamping for 60 seconds or till the first breath to achieve hemodynamic stability. We talk about gentle lung inflation. It's an awareness issue with a bag valve system. We don't have T-pieces, so we can't provide PEEP. And it's an awareness to be gentle with that bag valve to not damage the lungs too much. In the hospital setting, we talk about varying the oxygen concentration for the preterm baby. In the out-of-hospital setting, it's not really feasible to have variable oxygen concentrations. So here we're talking about air to begin with, bearing in mind this is dry gas, air to begin with and air to continue with until such time as oxygen might be available in certain situations, which we'll come to. Saturation monitoring, again, a compromise. Monitoring of preterm babies or even term babies in the out-of-hospital setting is a challenge. Very rarely are there neonatal or paediatric saturation monitors, so what might be used is an adult monitor, and the challenge of using that on an extreme preterm is something that is technically difficult if appropriate. So as we move down the algorithm, it's the same. Colour, tone, breathing and heart rate are the assessments. Breathing and heart rate critical to determining what happens next. And the rest of the algorithm, as it's presented in the publications and in any analysis, you'll see is exactly the same. There is no change to airway management. CPAP is not feasible in the out-of-hospital setting. There is no change to respiratory support. It's 5 inflation breaths and ventilation breaths once inflated. PEEP is a challenge in the out-of-hospital setting. There might be some bag valve systems that provide PEEP, but in general, PEEP is not provided by bag valve systems, so this is not something that can be expected. And the monitoring may or may not be available. There is no change to airway manoeuvres. The airway manoeuvres that are found to be successful in an in-hospital setting are the same manoeuvres that are found to be successful in an out-of-hospital setting. 2-person airway and breathing support is technically better than 1 person, but in an out-of-hospital setting with limited personnel, there may be many other things going on, looking after both the baby and the mother, but nevertheless, 2-person airway support for the preterm baby is certainly better than 1 person. Should there be an obstruction or a failure to respond, then suction may be considered, but this requires suction to be available, and that's a challenge for some situations. The use of other adjuncts is challenging in the very, very small baby. In the term and the sort of larger baby, adjuncts such as a laryngeal mask might be used. In the extreme preterm, these aren't things that can be expected to be used. And similarly, the use of increased inflation pressures where lungs are not inflating is something which can be regulated and controlled in a hospital setting, but in an out-of-hospital setting requires judgment of the people using the equipment. As we move on down the algorithm, you can see that again, the guidance for circulation is very similar. There are no changes to the indications for cardiac compressions in general, which is for a persistent very low heart rate, i.e. less than 60 or absent, despite the open airway and 30 seconds of effective ventilation. And the guidance for the provision of compressions is also the same in the newborn. Obviously, unless you've got oxygen, you can't give oxygen. Of course, we're not talking about all babies today. We're talking about the extreme preterm, and after some discussion, the guidance is that for those babies under 24 weeks gestation, where airway breathing support has been established and the heart rate remains low, chest compressions are unlikely to be helpful and are not recommended because of a recognition that a baby in that situation where it's not responding to the airway and breathing maneuvers is unlikely to survive. And therefore vascular access and drugs, whilst the next logical intervention on the newborn algorithm, they are not appropriate in babies where you would not be providing cardiac compressions. Obviously, in those babies where you would provide cardiac compressions, then consideration of the vascular access and fluids becomes relevant. So for larger babies, the NLS algorithm is the same and venous access might be considered. For those in the out-of-hospital setting, umbilical venous catheterization might be something that is difficult, and certainly paramedics in other countries would favour the interosseous route in the more mature baby. But it's not felt to be appropriate in these extreme preterm babies where the outcomes are very poor. So we come to failure to respond, which is a difficult and challenging situation in any case, whether it's in hospital or out of hospital. The guidance in the NLS setting is that at 10 minutes, everything should be reviewed. And if there's no heart rate from birth, people should be asking, well, are we doing everything we can? Have we achieved what we need? Should we be checking the airway, breathing and circulation? What about reversible factors such as pneumothorax, hypovolemia or congenital abnormalities? That's a difficult situation in the out-of-hospital setting, and particularly in the extreme preterm baby. And the appropriateness of continuing resuscitation might be discussed where there's been no response to all measures and arrival at hospital is going to be more than 20 minutes from birth, recognising that at 20 minutes, if there's been no response, outcomes are universally poor. As has been mentioned, resuscitation is something, or stabilisation is something that is not a dynamic situation at one point, but a dynamic situation in transit. So interventions and manoeuvres that are started at the place where the birth has taken place will continue and need to continue in transit, and that's a technical challenge, maintaining the quality of airway and breathing support. So in essence, the guidelines haven't changed. They've been reviewed. Consideration has been given to certain situations for these particular preterm babies where it's clinically felt to be appropriate to make some judgmental changes, recognising the limitations in the community. Environment, equipment, staffing and geography are challenging factors which need to be taken into account.
Thanks, John. That was a privilege to listen to. Thank you very much. A great resume of NLS and how we've adapted it to be able to provide pragmatic advice for this situation. We move on to the fourth and final scheduled talk of the morning, which is my colleague Alan Jackson, who is a neonatologist in Glasgow and is also clinical lead for the Scottish Neonatal Transport Service. And Neil alluded earlier to the four kind of tenets of the document, and the third of which was the correct destination. So Alan, you're the man with all the answers, aren't you?
So thank you for that introduction, Helen. Helen's office is right next to mine, so we've been able to liaise on this. My name's Alan Jackson, and as Helen's already said, I work between Greater Glasgow and Clyde Neonatal Unit in the Princess Royal and the Scotts Star Transport Service, and I'm here to talk to you all about destination decisions, all that stuff we've heard about what you do with these babies. Then, well, if you're in an ambulance, what you really want to know is where then to take them. So let's give a bit of background, particularly to those out with the neonatal sphere of things. So it's a highly specialised area looking after an extreme preterm infant. Part of the reason for that is because there's not that many of them, across the country in 2020, which is the most recent figures I could get. There was only 1,700 babies under 27 weeks born around England. If you start to share them out or across the different neonatal units, that's not very many in any area. And that figure is also sort of swayed much more towards the upper limits of that. So the 23, 22 weeks are much, much smaller numbers. And I hope that people are all familiar with lots of things, cardiac surgery, neurology, lots of things. What you really want to be doing is concentrating expertise for high complexity and low volume medicine. And that's been done for neonatal medicine with a smaller number of NICUs or level 3 centres who are supported by a bigger network of level 1 and 2 or local neonatal units and special care units around the country who care for babies whose needs are a little bit lower. But the population that we're talking about, care of them is very much concentrated in a relatively small number of NICUs around the country. And the relevance of all of that, as well as just making sure people understand the picture, that there's lots of maternity and neonatal units that will rarely deal with these extreme preterm babies because great efforts are made to make sure that they deliver in the appropriate centres. And even more importantly, most emergency departments will deal with these babies pretty much never. It'll be a once in a several years sort of situation to be presented one of these babies. So clinically, why does that matter? Well, hugely challenging thermal care for these tiny wet babies who lose vast amounts of heat and in fact water through their skin, and we've been hearing from John about the use of plastic bags around that. And we know that the profound hypothermia that some of these babies can experience is associated with morbidity or mortality, and even keeping them warm in a labour ward going straight into a neonatal unit can be challenging at times, never mind doing it in a bathroom floor at 2 o'clock in the morning. Their lungs are a major issue. They're really difficult to inflate, but if you can't inflate the lungs, you can't oxygenate. And if you can't oxygenate, well, you know what happens if you can't oxygenate someone. And that's particularly difficult trying to mask ventilate somebody who you could fit in the palm of your hand. And even those of us that are experienced this can find adequate lung inflation just with mask inflation can be really pretty tricky. And as well as being difficult to open these lungs up, there's a risk to longer term lung injury as well if you're overdoing it, but that's rarely going to be the problem in the pre-hospital setting. And this is a population with a very high risk of brain injury, particularly from intracranial bleeding, with long-term disability as a consequence of that. And initial stability certainly plays into the risk of all of that. So they're a clinically hugely challenging and tiny and very fragile group to be looking after. As well as the clinical aspects, there's some undoubted human factors issues. And let's go back to mum, or potentially other family members that have maybe seen this, as I say, birth in the bathroom floor. They'll be hugely traumatized by all of this and hugely concerned, and that will need careful handling. And we also need to think about this from the clinicians. For people that don't do the job that John and Helen and I do, this is probably one of the most terrifying patient groups to being asked to care for. And actually, I think most of us admit to not relishing the prospect of going down a labour ward for a 22 or 23 week baby, because even for those of us who do this for a living, they can be a challenging group to look after. So looking after a patient when you're terrified does not mean that you're going to provide the best of care. And we need to make sure that we're always remembering, and I need to remind myself about this because I just look after the babies, that we're talking about 2 human beings here. So we've got a mother that also is an important part of all of this. Now, obstetricians will tell me off for saying this, but most women after an extreme preterm delivery don't need highly specialist maternity care. There's the usual things like risks of sepsis and postpartum hemorrhage that would apply to any delivery, but they will all require some degree of postnatal care. And they will require that care in the context of what has been a pretty traumatic experience, delivering a baby at home, fearing for its life, ambulance trip to the hospital, all of that. So whatever care they need, even if it is medically relatively simple, they need some very sympathetic dealing with. And I think that is all relevant to where we're taking these babies. So when you talk about where to take people and you take all the clinical and human factors, what it really boils down to from a practical point of view is an understandable desire to get people somewhere quickly versus a more overarching desire to get people to the right place. So let's break that down. Okay, so it may be that the nearest place you've got is just an emergency department of a hospital without a neonatal unit, without maternity staff. So that's going to be quick. Big sigh of relief. You're going ambulance crew, but going somewhere they know. They'll be in and out of that ED all the time. They'll know the phone number. They'll recognise the triage nurse on the desk. Great sense of relief. But you know, I think it's a massive understatement to say that staff are unfamiliar with managing extreme preterm infants. They certainly would be relatively unfamiliar with the postnatal maternal care and managing the trauma with that. And it's certainly, I don't think anyone would think an A&E, particularly the way they are at the moment, is a good environment for dealing with this kind of horrible situation. So beyond being quick and familiar, there's not a lot to recommend your local ED for dealing with this scenario. And mum and baby will then need to be transferred somewhere else. And the neonatal transport service that will come out, they're not operating on an immediate dispatch basis, so that could take some time. And all of that will contribute to worse outcome psychologically and potentially clinically as well. So maybe the next best option is a maternity unit that's nearby, but it's not a level 3 NICU. So that maybe will be quick or quickish. Well, at least you'll be able to get the baby to a place where staff have some familiarity with looking after newborns and mothers, but they still won't be an expert group in managing the extreme preterm babies. And it will therefore, there'll also be another postnatal transfer, which may take some time as well. From an ambulance service point of view, maybe going to your local maternity ward is not quite the same as going into your ED. Maybe you don't have the phone numbers, maybe you're not so used to the pre-alert system, so maybe that doesn't seem so attractive. Oh, somebody is trying to get control of my presentation. Is that some immediate feedback or somebody just pressed the wrong button? Maybe just get rid of that and take back control myself. Is that okay? And then we've got, oh, sorry, that should say NICU maternity unit. Sorry about that. So the next option is a level 3 unit. So that is the place where mother and baby can get appropriate and expert and highly complex care. There's no further transfer required. It might, however, be a bit of a longer journey. And as above, if you go straight to the maternity ward, it might be a pathway that's not quite so familiar to ambulance crews with all the procedures in place for that you might have for an ED. So taking all of those factors, what are our recommendations? Well, absolutely essential is that there's a clear plan in place that everyone understands. Okay, so we can't exactly dictate from the group that wrote these guidance exactly what to do for every postcode in Britain, but there needs to be a clear plan of where to go, how to call pre-alerts so that people are waiting, know what to expect and to get themselves organised for this mum and baby coming. It's agreed and understood by all. And that means ambulance services and your local networks or ODNs, or however it is organised, depending on the situation in your area. We need to be absolutely, as has already been said, supporting crews and what they do and making sure there's no kind of what the Americans call Monday morning quarterbacking of that. And what we recommend, that you need to be, wherever possible, taking the mothers and babies to the same site, and that site should be somewhere with neonatal and maternity facilities. You really don't want to be separating them unless it's absolutely necessary. It would be very traumatic for a mother to be separated from the baby under those circumstances. And again, we say that wherever possible, you should be trying to get to a level 3 NICU rather than an SCU or an LNU, but obviously local geography may dictate that being impossible in certain circumstances, but it certainly should be considered. And that should be considered even if there's a substantially longer journey. And a final level of detail there, there's variable opinions on this. I think I need to be very clear, but the consensus is in general, the best place to be taking this baby and mother is to a labour ward, delivery suite, or some part of the maternity building, rather than going to the emergency department, even within the same facility. It's really not a good environment for dealing with these patients. It can be very challenging for neonatal staff to leave the neonatal unit and the maternity hospital and get themselves to ED. So getting them to labour ward is very much preferable should that be practical, but there may be local considerations that mean that that's not always possible and not as simple as we might make out. So in summary, you know, this is a hugely challenging area clinically and psychologically. We must make sure we're working together. These are rare events, so you want to have a collaboratively worked out plan that makes sure you're not trying to wing this on the day, because that is traumatic for all involved. We need to make sure that ambulance service are well supported so that there are clear pre-existing pathways to follow, and nobody's deciding to say, oh, you should have done that or you should have done that. It should be black and white what the right thing to do is, and fully supported by everyone. And we should make sure that there's a welfare check, or whatever the terminology your trust would use, for checking in with the team that have been in the house dealing with this very difficult situation, providing that feedback that's already been referred to make sure that there's good support in place. And that is me, and hopefully that means we're a little bit ahead of time now.
That's great, thanks Alan. That's us bang on time actually. So what we're going to do now is open the floor to questions, chat. Just to reiterate, thanks to 4 people that have covered the document very comprehensively for us. Perhaps I'll just start maybe while people are thinking, and there was a comment from Rachel Collum about, for those that are not on the chat, it says, presumably there's some join up between the NICE guidance on preventing preterm birth in this framework. Yes and no. Nobody wants preterm babies to be born, and we certainly don't want them to be born out of hospital. I think respectfully these are slightly different documents, because this document we have by definition is the unexpected preterm birth. So to my mind, if there was to be any tie-up, it would be that ladies who are attending a specialist preterm birth clinic would be made very aware of potential signs of early preterm labour and actually would be at home. So we don't really want to be managing extreme preterm birth in the community. And that also takes us on to one of the feedbacks for the document was sending out neonatal transport teams, emergency out of hospital preclinical teams to manage the situation in the house. And what not the majority, the overwhelming opinion of the group is that preterm birth out with hospital, extreme preterm birth, is not good, and it's a very time critical emergency. So the main risk to this baby is that the baby's going to get cold, and the sooner you get the baby into hospital. In reality, I think what we're trying to get across here is there's not an awful lot you can do for an extremely preterm baby out with hospital, except try and keep them cold, try and keep them warm. Freudian slip there. They will get cold very easily, very good at getting that. So it's to try and keep the baby warm and provide basic airway management. So I'm just looking here. There is a hand up. I'm not able to see who all the individual hands up. So I got a hand up here. Because somebody who's got their hand up, maybe just
it's James Y. I can see. I don't know.
Right, I can't.
Shy
Right,
about your second name.
James, would you like to come in? Oh, there you go. Thanks very much. Hi, pleased to meet you. Maybe you could just say what your role is, and then give us your question. Thanks very much.
Sure, thanks ever so much. So I'm James. I'm an advanced paramedic with the neonatal retrieval team in Bristol, but I also work as a specialist paramedic for one of the pre-hospital critical care teams on the air ambulance in Bristol too. So kind of fairly invested in this process from both sides of things. And I guess, I mean, first of all, I think this is a great bit of work, and I think really needed. I think there's going to be some interesting challenges regarding lobbying ambulance services to carry the right equipment to deal with these patients appropriately, but also to ensure that crews are feeling appropriately trained and up to speed with these guidelines. But actually, my question is more around the 999 triage system, actually. And I think particularly, you know, with adult medicine, there's a lot of focus, isn't there, on bystander and layperson interventions before the arrival of the ambulance crews. And I just wonder if any thought has been put into the advice that's given by the 999 call handlers regarding these sort of extreme preterm births. And certainly, historically, and I don't know whether it's changed, if you had a birth pre-hospitally below 24 weeks, the guidance that you would be given by the call handler would be that this was a miscarriage and that there was nothing that could be done. So I wonder if that's been updated, and I wonder whether, given that the basics of thermal care and airway management can be, could be maybe advised over the phone, whether there's some interventions that could be done prior to the ambulance service arrival.
Thanks, James. Those are good points. Amy, would you like to come in on that?
Yeah, absolutely. Hi, James. Nice to see you again. Thank you so much for your comments. I completely agree, and it's such a shame that Amanda's not here, because Amanda has done absolutely amazing work with one of the triage systems that's used. So the triage systems, for those of you that don't know, there's two triage systems that are used in the pre-instructional arrival for the triage of treble 9 calls. The one is the AMPDS, and it escapes me now, it's the Advanced Priority Dispatch System, which is an American system, an American-based system, which is a worldwide system. And the difficulty with getting anything changed in that system is that it has to go through several layers of international bureaucracy as well as our own. I'll come back to that in a second. And the other system is NHS Pathways, which is obviously a UK-based system, which is a little bit easier to tweak, but still has the associated bureaucracy. So it is something that has been made aware of and looked into. Pre-instruction arrival notifications should be based on the clinical signs of the infant that is placed in front of them. So a baby that is showing signs of life should be triaged appropriately because of those. The changes that have happened quite recently are in and around the whole cord clamping aspect of things. So there has been a previous where the cords were tied with shoelaces, etc. That has now gone out of the guidelines. So delayed cord clamping is very much promoted in both sets of guidances. To answer your question quite shortly, because I don't want to take up too much more time, but the answer is it's not in the process at the moment, but it is something that is being looked into by Amanda, myself and Dawn, definitely.
Great. Thanks, Amy. Yeah. Thanks, Amy. I'm just checking. Did I put my mic? I've got my mic on. So thanks, Amy. That's one of the other questions are coming in thick and fast here, but one of them is from Katie Broadbent, was about skin to skin regarding thermal care. Now, Katie, we did discuss this. I'll maybe just say a word on that and then see if anyone else wants to come in. In reality, a baby under 27 weeks is likely to be needing some respiratory assistance on the way into hospital, and giving what the group thought was that giving bag mask ventilation with a baby in skin to skin contact with its mother is somewhere close to impossible. And also, if you're going to go skin to skin, you would have to take the blanket off of the baby and leave the baby in the poly bag, but you'd have to take the blanket off. So all in all, it was difficult to see how that would be advantageous to an extremely preterm baby. So I see John's said, yes, it works. Of course it works. It works in the bigger babies. But John, I don't know if you wanted to say anything else about the real teeny weenies.
That's why there's another comment. It says care is required in monitoring and supporting the airway and breathing with skin to skin. And I think that's the critical thing here, is we know that skin to skin is great. It's wonderful for a number of reasons, not just because of thermal care and infant stability. And for the bigger babies, that it's just what you should be doing. I think with the smaller babies, there's a sort of tension between the wish to promote skin to skin, which works, and it also does provide thermal stability, but the need sometimes to intervene or to support airway and breathing, and it can be a challenge. And for babies that are requiring intervention, I think skin to skin is possibly something which is desirable but not achievable, certainly in the immediate time when you're actually having to intervene on that baby. So yes, totally agree that skin to skin is something which should be acknowledged. Even with a baby that's swaddled and wrapped and plastic wrapped, you can provide a certain element of as close to skin as possible, I think.
Thanks, and I see that Lydia's put in that you had a 24-week baby brought from home with skin to skin, the plastic bag, mask, ventilation, and she went home fine. So, well, I wonder, Lydia, are you on the line there? How far did that baby travel? That's I presume that baby was in very good condition at birth.
She was in good condition at birth. She took a breath. She was quite small. She was about 600 grams. And I just left the hospital and I got called back in. So it took me about 20 minutes to get back in. And I arrived at the same time as a baby. So it took her about half an hour to get into hospital. And the ambulance crews they'd just done an NLS course actually. So they had a plastic bag and they put baby skin to skin. Temperature was reasonable for that sort of history, but I think it was about 35 when she came into delivery suite. The paramedic was doing the mask ventilation as we walked up, and I could see chest wall movement because I met them at the door as it came in. So yeah, it's possible, but it will depend on the skill of your team, like a lot of these things. But I just thought I'd share that because we did have exactly that same scenario. But I would say, just because NLS also says use plastic bag only when you have an external heat source. And so subsequent to this, I think it was interpreted that we didn't use plastic bags outside hospital because we didn't have an external heat source in the ambulance. So I'm just interested again in that same conversation, because my experience is it had been very effective with mum as the external heat source, but we also do have the transwarmers, and you know, that's something simple that ambulance crews could carry.
Yeah.
If you to enable you to continue effective airway management in a difficult situation with a crew who have a very large mask and a very small baby.
Yeah. Thanks, Lydia, and thank you for highlighting the bit about the poly bag. So we are absolutely clear that you will never go wrong with a poly bag as long as you put the baby in feet first, because anyone who's got standard grade or O-level physics will know what you're doing is reducing evaporative heat loss. You don't keep the baby warm in a poly bag, so you have to wrap the baby again in a blanket if you don't, or ideally an extraneous heat source, mother, transwarmer, whatever. But that it's easier just to say blanket, not blanket, sorry, that's an unintended pun, just a blanket recommendation that every extremely preterm baby goes into a poly bag, and that's going to be in the upgraded JR Calc guidance. Alan, you've got your hand up.
I have, Helen, just because I'm scanning the comments as they come through, and there's a question there from Una that I know we talked about quite a lot, and I think was probably worth bringing out. Hello, Una, nice to hear from you. So the question is about parental wishes. Parents maybe didn't want their baby to be stabilised and taken to hospital, or to have life-prolonging treatment applied in this sort of circumstance. And I was just aware that we talked about that at quite some detail. I think the general feeling that was, having dialed 999 and asked for an ambulance to come, then there would be some expectation of life-prolonging treatment to be put in place, and that really the people that should be making a decision about stopping or continuing treatment should be consultant neonatologists in a neonatal unit, and that not being something that could be fairly asked for people to do on the bathroom floor at 2 o'clock in the morning. Clearly, if there is some background to this where there's an anticipatory care pathway in place, or some background to this where there's a clear wishes are being expressed, then the crew may wish to ring and discuss that. But we really felt that we wouldn't want to sort of override parental wishes in any particular way, but that was a conversation that the people like me should be having rather than someone in the house. Is that a fair representation, Helen?
Yeah, thanks, Alan. I'd actually seen that comment myself, so I think that's really important. So again, more, I think, for the ambulance crews here, you're not going to do any harm in wrapping the baby in a poly bag, wrapping the baby in a blanket, applying a transwarmer if you can, and giving some inflation breaths. If the baby is pre-viable, is not going to survive, you're not going to prolong life by these manoeuvres. But equally, the other side of the coin is that if the baby is perhaps more mature than was recognised or anticipated at delivery, there might then be repercussions for not having provided neonatal care. And certainly in my experience, the parents who want nothing done are a minority, particularly if it's unexpected. I think somebody's maybe got a mic on there. So I don't know if anyone else wants to contribute to that conversation. I see Tesco bags. I have to say, many, many years ago, we started with Tesco freezer bags for babies before we had posh, sterile, keep your baby warm bags. So yes, Tesco bags. And there are, of course, other supermarkets, but any kind of bag's fine.
So Helen, I think the key, there has been confusion about the plastic bag thing for years.
Yeah.
And you know, I've heard the debate go back and forth about this, and there's been quite a lot of contention. But the bottom line is, plastic bags work, as you and I know, whether you're dry or wet. And if you're dry, fine. If you're wet, providing you then wrap the baby and provide some element of radiant heat, the plastic bag ain't going to cause harm. Mum is a radiant heater. An exothermic mattress is a radiant heater. In the hospital, it's traditionally a resuscitaire is a radiant heater, but anything that provides heat is radiating heat. So providing you can get that baby to a source of heat, we know it's thermal air, the thing that's done badly, and cold babies come in. So anything that can be done to get that baby warm is a good thing. And just thinking about it in an intelligent manner and having that bit of kit around could be a vital bit in making that baby a better baby.
Yeah. Thanks, John. I'm afraid I can see another hand up that says plus 120. So someone else has got their hand up, but I'm afraid I can't see who it is. So if you would like to just put your mic on and chip in, that would be great.
Looks like it's Oliver.
Hi.
Oh, hi, Oliver.
Hi, Helen. It's Oliver Rackham. I'm a consultant neonatologist in North Wales.
Good to see you.
So two things I was just going to say, although I've been listening to the comments instead of thinking about what I was going to say. I mean, the bit about the bags is people talk about, oh, I suppose I could just use a Tesco bag, but actually that's what all the research was done in. So you don't need to buy an expensive wrap.
Other bags are available. Oliver.
Yeah, sorry.
Just to clarify.
yeah, sorry. But a food grade bag is exactly what it should be. Oh, it's gone out of my head what I was going to say. That wasn't my point, though. Sorry. Just wanted to come in on that. Oh, dear.
You put in a comment about daylight hours, Oliver, was that?
It wasn't that. I was just, oh no, it was about the limits of viability. I quite understand the point that we shouldn't be putting people in that decision making, but the parents might have no idea. So they might quite appropriately call an ambulance, and then it would be possible, particularly with neonatal unit input, to have a discussion and say, actually, the outcome at 23 weeks is this, roughly. And it might be possible to have some kind of conference call and have that discussion rather than continue. And you still might bring the baby in afterwards. But I can see situations where using this framework, people might be able to make a good decision for the benefit of the family and the baby. Not very challenging, but this whole thing is challenging.
Thanks, Oliver. We did discuss in the group, and one of the drafts of the document had something in it about calling the neonatal units. And then, as I said, the overarching description of this document, I would hope, is pragmatic. Most people, when they call a neonatal unit, get round and round the houses, and we get lots of advice. So the worry was that might actually defer the need to just wrap the baby up, keep it warm, give some infusion breaths, and get to hospital as quick as possible, because it would be very difficult to give advice over the telephone if gestation is unknown. But that might just open up a debate for someone else. Alan, you've got your hand up.
Yeah, it's kind of on the same point, because I can see there's more comments coming through. I mean, we're not in any way trying to override parents' wishes here. I think we also need to be very clear that at the gestations where that's an issue, really 22 and the kind of lower 23-week gestations, giving some mask ventilation and putting them in warming them up and taking them to hospital is not going to, it's not going to work. I think we need to be clear about that. So I think the fear of providing life prolonging and sustaining treatment to someone who then goes on to suffer against the parents' wishes is actually a pretty unlikely scenario. And the great majority of times, but at these gestations where you do have those big discussions about the ethics of carrying on, you're not likely to do this. And I think the chances of someone inadvertently prolonging life in someone where that's against the wishes is extremely small. But yes, I mean, we should absolutely be respecting parents' wishes, but I think this is not really the scenario where a detailed discussion about pros and cons of carrying on is likely to be practicable.
Thanks, Alan. The other point was about the transwarmers. Just for clarifying, again, that was one of the draft sentences that came in and out of the document, because we recognise that recommending transwarmers has a cost implication. But again, there's also the issue, think about rotating, you know, the neonatal units do use transwarmers from time to time, and if there was reasonable housekeeping and rotation of stock, there shouldn't be so much wastage, I would hope. But maybe people would have another opinion on that. Do feel free to come in.
So, at the risk of just standing on a pedestal, they're 20 quid or less. It's not big bucks when you consider some of the things that we spend our money on, and they have a shelf life of 2 years or more. So they're sort of useful, and they might have application outside the extreme preterm in other cases of hypothermia and or other reasons to raise other patients' temperatures. So it seems to me they're a potentially useful adjunct, and somebody up on the chat mentioned about rotating stock, and that's a potential thing to consider with your local unit as well. So I don't see that the transwarmer is something which is a problem. I think they save lives.
Thanks, John. Very helpful. I noticed there's a question from Anya Letty, neonatal, to say that the current BAPM preterm management guideline does not limit chest compressions for extreme gestations resuscitation. How did the ambulance guideline choose 24 weeks as the threshold for not performing chest compressions below 23 plus 6? Well, this comes back into this pragmatic word. What we felt is that a 23 week baby born out of hospital is not the same as a 23 week baby born in hospital. You've had no antenatal steroid, you've had no magnesium sulfate, and that shifts the risk for the baby to a poorer prognosis. So it was a pragmatic decision. I would open the floor to discussion on that one, because I think what we're trying to do also in this meeting, where, you know, a lot of the discussion here has been about the baby, but the other people to think about here are the ambulance crew on the ground. This is just, I mean, I would be scared if I was out in somebody's house and a baby was 23 week baby was born on the floor, and as Alan pointed out, that's what we do for a living. So what we're also trying to get across in this document is that you are very unlikely to do harm. All you can do in the community setting in a baby who's not been optimised for preterm delivery is to keep the baby warm, try and inflate the lungs, and head for hospital as soon as possible. Alan, you've got your hand up again, thanks.
Well, yeah, and we should also emphasise, Helen, that no one would be criticised for giving some chest compressions at 23
No.
3 plus 5 or whatever. I think it is more to try and get across, you know, in a totally unoptimised delivery setting that it's very unlikely to be of any benefit. But absolutely nobody would be criticised, and it would be entirely understandable if all horrible things going on, someone gave some chest compressions. So it's not meant to be something that people need to be scared of doing. It was more to relief if they feel that that's something they're obliged to do.
I see Graham Walker from the Ambulance Authority has, it's not a silly question at all, Graham, why we only talk about polybags in the context of neonates and not all pre-hospital births. As far as I'm aware, it's because there's been no study conducted, thus not evidenced, but the same logic would apply. Yes, the same logic would apply. You will reduce evaporative heat loss, but a term baby is better covered, obviously better insulated. And for most term babies, then skin-to-skin care is going to be practical, but you're certainly not going to do any harm ever with a poly bag, but probably not necessary in term babies. Anybody wish to join in on that one?
So
I think
how,
the question maybe is what your gestational cutoff would be, because this is talking about extreme preterms less than 27. So, you know, in hospital we would use them up to 32, for example, and that wasn't really the remit of this group, but it is probably a question that needs to be addressed at some point as to what is the cutoff for polybag use.
So there is evidence to suggest that plastic bags are actually a benefit in all gestations, but There are other reasons why you might choose not to wrap a term baby in a plastic bag and a towel. Skin to skin is somewhat impaired if your baby is wrapped in a plastic bag, for example. So for me, arguably the greatest benefit for the use of a plastic bag is in the preterm baby, where there are challenges in maintaining thermal stability, and your term baby and the late preterm baby have other mechanisms to maintain thermal stability. So the net benefit of the plastic bag is arguably more marginal in the larger baby. So we talk about plastic bags in the preterm baby because the evidence suggests that this is where it has its biggest impact, providing it's used properly, of course.
You're on mute, Helen.
Sorry, I was going to say feet first. Does anyone have any other questions? I don't see any more hands up at the moment. We still have a few minutes more if anyone would like to chip in here. I hope we have managed to clarify some of the points. I think the points that were most contentious in the description was the one about polybags and whether you could use a polybag without a radiant warmer, and hopefully we have laid that one to rest. I think that's the main, and the other, oxygen. I don't know, John, did you want to come in about the oxygen? We've said to use air in the ambulance for several reasons, and we may actually put a rider into document, but John, maybe we'd...
Yeah, so this was, this is, thanks for that, Helen. If you read the standard guidance, it's resuscitating air, but for preterm babies under 32 weeks, there's variance in that, and the guidance suggests that under 28 weeks you'd start in 30%, and between 28 and 32 you can vary it, and obviously that's not something that's available universally to ambulance crews and those in the home situation. So there was quite a bit of debate about this, and so the decision was made to start in air because it's pragmatic and oxygen's not always available. And in reality, the evidence for the benefit of oxygen is a bit unproven, I guess. The guidance is to turn to 100% if you're starting cardiac compressions. And in the home situation, the use of oxygen is a bit uncontrolled and unregulated. You don't really have a much choice between air and 100%. So I think we decided with this document that it would be air unless you got to cardiac compressions. But if you'd got to cardiac compressions, then it's not unreasonable to say that if you've got oxygen available, to introduce oxygen at whatever concentration you've got into the system. But it recognises the compromises that exist in the out-of-hospital environment. The blenders and the monitoring and the saturation monitoring that we've got in hospital are not always available to those in the out-of-hospital setting. So it's not reasonable to expect that level of monitoring rigour in the out-of-hospital setting. It's a compromise. I think our rider was that if you'd got to cardiac compressions, it was reasonable to give oxygen in that situation if you had it available, which I think is reasonable.
And it's cold, of course. The oxygen that comes out of an ambulance will be cold, which is very good.
But actually we dry gas ventilate at resuscitations as well, even though there is evidence that humidification can help thermal stability. We continue to use dry gas ventilation even in the labour ward in a hospital at the moment. It's dry gas that comes out of those ports.
Okay, I think that's been a very helpful discussion, and thank you very much. So the questions have been whizzing around on the screen here. Thank you very much to everyone that's contributed. Does anybody feel that, Marcus, you've got your hand up. Would you like to? Is that?
I was just trying to press the applause one.
All right. Thank you very much. Does anyone have any more questions? Otherwise, we will draw this to a close. Thank you very much. There was a lot of feedback. Yes, and thank you, George. I was going to put that in my request as well. Somebody put in a question saying they were only an ordinary paramedic. Thank you very much for George for commenting that there is no such thing as an ordinary paramedic. I think you're all great. I hope this is a situation that will be theoretical for all of you, but should the occasion arise, we do hope that you would perhaps feel a little better equipped to deal with an extreme preterm birth out of hospital. So that just remains with me to thank very much the fantastic team that helped put this document together. I know that Amanda and Amy that kicked it off in the first place. Lucy's been very quiet in the background there. Lucy, who chaired up the Signs of Life guidance for Embrace. It was Lucy that brought the paramedics and BAPM together. We hope that what we've produced is helpful. I hope we don't need to use it very often or ever. And I just hope that you all have an enjoyable rest of the day. So thank you very much for attending.